Ciao tutti, Jim Fanelli here, Wilmington, North Carolina, with another edition of CE in Italy and Europe's Tuscan Discussion. Today, we're going to be discussing a clinical conundrum that we see fairly regularly in clinic, and that is one of the patient who presents with a swollen disc. And the question that we have is this papilledema, or is this in fact something like Disc Drusen? Now the differentials here are numerous, and I'm going to limit this particular discussion to simply papilledema versus optic disc drusen, because there's a big difference between optic disc drusen, which we know is a situation where we monitor the patient, versus papilledema, where there is vision and life-threatening issues at hand. So first of all, the difference between disc edema and papilledema, we need to discuss that first. Technically, and we need to get this down straight, the definition of papilledema means swelling of the optic nerve related to increased intracranial pressure. Whereas the term disc edema means that there is swelling to the disc that may be due to an optic neuropathy, it may be due to diabetic papillitis, but it is due to a condition other than increased intracranial pressure. So papilledema is reserved for instances where there is disc edema, and it's usually bilateral, that is associated with increased intracranial pressure. In the early stages of disc edema, secondary to increased intracranial pressure, it has some of the similar signs clinically that optic disc drusen have, especially if optic disc drusen are in fact buried. But the key here is what we can see, for example, on MR findings. MR findings give us a pretty good indication of what we're going to see in our clinic when we utilize OCT technology. And for the most part, since OCT technology is readily available for all of us, we have that technology in our office, and we can use some of the clinical differences in OCT images between papilledema and optic disc drusen to guide us as to which of those two diagnoses we actually have. So if we take a look at an MR image of a patient with increased intracranial pressure, we know that increased intracranial pressure can be caused by a variety of issues. This could be vascular, it could be venous sinus thrombosis, it could be a subarachnoid hemorrhage, subarachnoid leak. But the common denominator is that the pressure in the subarachnoid space increases. And that increase in cerebral spinal fluid pressure in the subarachnoid space is transferred along the subarachnoid space surrounding the optic nerve. Remember, the optic nerve is characterized by the neural tissue centrally, but in the orbit there is surrounding the optic nerve. If my finger is the optic nerve, there's an optic nerve sheath, and around that sheath lies the cerebrospinal fluid. So when cerebrospinal fluid pressure is elevated, the sheath does not have the opportunity to expand. What happens is the pressure in that subarachnoid space begins to compress the optic nerve fibers in the orbit. That also tends to push the optic nerve flat up against the back of the eye. So some of the findings that we're going to see in an MR image is going to be distension and swelling and compression of the optic nerve and the optic nerve sheath. But we're also going to see flattening of the posterior sclera because of movement forward of the optic nerve in this area. Now, when we have increased intracranial pressure, as a result of the compression of the optic nerve, we're going to disrupt axoplasmic flow. And that axoplasmic flow will result in a disruption of both the structure, i.e. papilledema that we see when we look in fundoscopically, and also dysfunction of the optic nerve. In other words, visual field defects, vision loss, etc. So this issue of axoplasmic flow is directly related to the compression of the optic nerve behind the globe when intracranial pressure is elevated. Okay, so what does that look like when we look at the eye fundoscopically? Well, certainly we're going to see elevated disc margins, and that this can look very chunky, very full. But in the case of buried disc drusen, it can look very similar, and therein lies the clinical conundrum that we have. Does this patient have disc drusen, or does this patient have papilledema that needs to be urgently scanned? Our OCTs invariably will help us to make that differentiating point. Again, in the context of papilledema, we have a situation where increased intracranial pressure is compressing the axons. The axonal flow becomes stagnant, and we get both cytotoxic and vasogenic edema due to this compression. But when we look at these optic nerves from an OCT perspective, we're going to see a couple of things that help us to differentiate this from optic disc drusen. Number one, because the cerebrospinal fluid and intracranial pressure is elevated and is pushing on the back of the globe, we're going to see forward bowing of the RPE Brooks membrane complex, especially nasally, when we look at these images on OCT. Invariably, and there are exceptions to every rule, but invariably in papilledema, we're going to preserve some of the optic cup. Now, as papilledema progresses through the several Fluorescene stages, especially when it gets very, very significant, we can lose certainly the optic cup. But in early to moderate papilledema, the optic cup is going to be preserved. So we're going to see on OCT this forward bowing, and in fact, if this is the nasal aspect of the disc, we're going to see the nasal aspect of the disc somewhat be bowed forward. Usually, in a healthy eye, the posterior segment is going to have uniformity between Brooks membrane and RPE complex on the left nasal and temporal side of the nerve. So there's not going to be this disparity. That disparity occurs in about 2/3 of the patient, but not 100% of the patient with papilledema. Okay, so we're going to have that bowing. We're going to have preservation of the optic cup. The way that we need to see this on OCT technology is not using a perioptic RNFL circle scan. Think about it. If here is the optic nerve, and the optic nerve has some swelling to the neuroretinal rim here, our perioptic RNFL circle scan is going to be well outside of that area, and our perioptic RNFL scan may oftentimes be in fact normal and not show any aberrations. Obviously, if that nerve is significantly bowed forward, then the perioptic RNFL may pick up defects. But that's not really how we want to look at the optic nerve. We want to take radial scans, cross-section scans through the optic nerve so that we can see the neuroretinal rim at 180 degrees apart from each other and see what's happening deep inside and behind that at the level of the RPE and Brooks membrane. Now, in patients with optic disc drusen, 2 points to remember. optic disc drusen eventually become calcified. And calcified optic disc drusen generally are relatively visible, especially if they are superficial. But if those disc drusen are buried, even if they're calcified, they're somewhat hard to see. We need to keep in mind that calcification doesn't really complete until the teen years. So younger individuals, 9, 10, 11 years old, who have swollen discs, who may in fact have disc drusen, those drusen are not yet going to be calcified. That's important because one of the highlights of fundus autofluorescence is that you can see calcified drusen. But in those patients who have buried disc drusen or who have disc drusen that are not calcified, again, we're going to use our OCT. We're going to take our radial scans, and there are a couple of differences between those scans and that which we see in papilledema. Number one, there's not going to be a deflection of the Brooks membrane RPE complex. So that very, very posterior, deeper OCT sections are going to have symmetric RPE segments on each side of the nerve. However, in disc drusen, invariably, there will be loss of the optic cup, so we won't be able to see a defined optic cup. And in disc drusen, especially if they are calcified, this makes sense, we're going to see hyperfluorescence or hyper intense imaging on OCT where there is calcification. And beneath those areas of calcification, we're going to see areas of signal hypointensity. So in optic disc drusen, there are areas of hyperintensity and hypointensity. And the other piece that helps us to determine or distinguish between optic disc drusen and papilledema is the fact that the RPE tends to remain flat, but because we're jamming these hyaline bodies into the optic nerve, the neurosensory retina oftentimes will be separated just adjacent to the optic nerve from the underlying RPE. So we have this recumbent V pattern that we see in optic disc drusen that oftentimes we don't see in papilledema. Now, the finer nuances of optic disc edema, this is a 2-hour lecture and it involves neuroimaging, it involves anatomy, it involves clinical care. I wanted just to cover the basics here for you and give you some of the generalities and some of the more common differences between the OCT images that we're going to see in papilledema versus optic disc drusen. Remember, if we have optic disc drusen or we suspect optic disc drusen, shoot a fundus autofluorescence. See if anything lights up, because disc drusen will light up under fundus autofluorescence. If you have access to a B-scan can also help to see and isolate optic disc drusen. You're going to see an elevated disc with a B-scan if you're looking at papilledema, but you're looking for those hyperreflective areas in optic disc drusen. In pediatric cases where there is suspected optic disc drusen, fluorescein angiography can play a role in differentiating these conditions. But it all boils down to, what are you going to do when you see this patient in clinic who has bilateral swollen discs? Can we call it papilledema? Only if there's increased intracranial pressure. We can call it a swollen disc or an edematous disc or disc edema of unknown etiology. But optic disc drusen, papilledema, very big difference in management. Hopefully this gave you a little bit of a primer on some of the more interesting findings that we'll see in OCT technology to differentiate these two conditions. Again, Jim Fanelli, CE in Italy, Tuscan Discussion. Our CE educational programs are scheduled for later this year, 2021, and all throughout 2022. Hope you can make it. Check out our website, www.ceinitaly.com. and I'll see you again soon. Ciao!